Uzbekistan. Dear colleagues, I would like to present our research work on the topic selection criteria for antibiotic therapy in pediatric surgical sepsis. High mortality in sepsis, septic shock, 30-51%. Upon admission to the ICU, sepsis is confirmed in 23% of cases. Long-term multi-component IC weeks, months, long-term ABT weeks, months. The number of pain-resistant strains of microflora is increasing. In line with international protocols, when sepsis or septic shock is confirmed, it is crucial to promptly establish venous access and begin infusions such as vasopressor if needed. Administering antibiotics should be done prior to taking samples for microbiological testing. Additionally, early nutritional support and other measures should be approved to enhance patient care. Evans et al. Study findings. Implementation of all recommendations for sepsis treatment within the first hour significantly increased children's chances of survival. Implementing only a single element of the guideline does not affect the outcomes. Discussion. Initiation of antibiotic therapy is a mandatory component of IC sepsis. Per the Surviving Sepsis Campaign guidelines, antibiotics should be given within 1 hour of ICU of emergency department admission. Medicaid and Medicaid services suggest a 3-hour window, while some meta-analyses allow up to 4 hours. However, due to practical constraints like diagnosis time and organizational issues, administering antibiotics within 1 hour may not always be feasible. There is no evidence supporting the 1-hour rule's superiority over later administration. Overdiagnosis of sepsis and increased antibiotic use contribute to a global crisis of antibiotic resistance. Administer antibiotics empirically within 1 hour of sepsis septic shock diagnosis. Ideally, blood cultures should be collected from different sites before starting antibiotics without causing delays in treatment. Antibiotic initiation timing in sepsis septic shock. SSC guideline outdated and lacks evidence, no consensus on validity, recent meta-analysis, no link between antibiotic timing and mortality, importance of microbiological, diagnostic, and antibiotic resistance knowledge. Discussion. Impact of timing of ABT, administration of mortality in pediatric sepsis. 1 hour treatment bundle in pediatric sepsis reduces mortality risk, improves outcomes, potential risk, sepsis, overdiagnosis, unnecessary antibiotic use, iatrogenic fluid or low, delaying antibiotics more than 3 hours post-confirmation, increased mortality in ICU children. SSC recommendations are a reflection of the world's best practices, not a command to action. Early ABT has an effect in the case of restored tissue perfusion and as a result of the implementation of the entire IC complex. or the clinical efficacy of ABT depends on the sensitivity of the microorganism to antibiotics, resistance, the concentration of the drug in tissues, its pharmacokinetics. The topic of the primary focus, the initial severity of the patient's condition and the tissue perfusion pressure. Purpose of the study: to optimize the diagnostic process and pathogenetic intensive care strategies for surgical sepsis in children by utilizing clinical and laboratory criteria along with bacteriological monitoring. Patient inclusion criteria for the study: children under 18 years old, confirmed sepsis septic shock, organ dysfunction 2+ signs present, pediatric SOFA score more than 3 points, procalcitonin level more than 0.5 nanogram per milliliter, availability of recurrent examination. Design research: identify predictors of sepsis in surgical patients by evaluating clinical MAP, heart rate, respiratory rate, oxygen saturation, and laboratory parameters within the first 48 hours of sepsis identification, as well as on days 4 and 8 of intensive care. Biomarker for calcitonin and SF protein. Predominant boys 60%, predominant abdominal surgical pathology 43%. Multi-component intensive care sepsis. Rational antibiotic therapy based on microbiological monitoring, respiratory support, mechanical ventilation in 36% of cases, transition from pressure control mode to assisted ventilation, correction of fluid, electrolyte, and hemodynamic imbalances, inotropic, nutritional, and immunoreplacement support, gas exchange monitoring using central venous blood saturation and blood gas analysis with saturation targets of 90-95%. Detoxification via plasmapheresis and hemodynamifiltration in 22% of cases. Intravenous immunoglobulin administration from the 4th day of illness for 5 days alongside complex pathogenetic intensive care. Nutritional support for surgical sepsis, energy equipment 25-35 calories per kilo BMI in the acute phase, 35 50 calories per kilo BMI in the phase of steep hypermetabolism. This preserved function of the gastrointestinal tract, enteral mixtures with pharmacokinetics, nutrients, glutamine, pronounced catabolism mixes nutrition of parenteral enteral nutrition is the functions of the gastrointestinal tract are impaired, complete parenteral nutrition. Characterizing the microbial profile of cultures from various sites. In blood cultures, predominant Staphylococcus coagulans negative 40%, Staphylococcus aureus 20%, from drains 32 Klebsiella%, Staphylococcus aureus 18, 14, Pseudomonas aeruginosa 23, Acinetobacter 20%, Sputum Klebsiella pneumoniae 28%, Staphylococcus aureus 23, 21, pneumococcus 11%. Isolation of the same pathogen culture from more than 2 locations confirmed sepsis bacteriologically and was considered etiologically proven. Results of microbiological monitoring in our research: Staphylococcus aureus, Pseudomonas aeruginosa, Klebsiella, Acinetobacter are the dominant species among the studied isolates. Klebsiella pneumoniae shows a higher prevalence than Pseudomonas. In blood cultures, gram-positive bacteria, including Staphylococcus aureus and coagulase-negative Staphylococcus, are predominant. Microbiological local monitoring: the most problematic microorganism, Klebsiella pneumoniae, Pseudomonas aeruginosa, Acinetobacter, MICI, Enterococcus faecium, Fungus candida. Causes of surgical sepsis: our analysis of the bacterial landscape changes revealed a consistently high proportion of gram-negative microflora among the studied isolates. Candida fungi were present in 12% of cases of part of the polymicrobial flora. Overall, gram-negative bacteria were the primary causative agents of sepsis in 42%. Gram-positive bacteria accounted for 30% and polymicrobial infections for 27%. The spectrum of resistance of the main nosocomial pathogens to ABT indicates the real situation of the inefficiency in the use of carbapenems in sepsis, since the level of resistance to the Klebsiella pneumoniae, Pseudomonas aeruginosa, and Acinetobacter reaches 53, 60, and 73%. The choice of antibacterial therapy was prescribed no later than 3 hours after confirmation of sepsis. Considering the patient's critical conditions, initial empiric antibiotic therapy combined 2 antibiotics, typically third and fourth generation cephalosporins plus third generation aminoglycosides, often with metronidazole for children with abdominal pathology. Etiotrophic ABT regimens were revised after obtaining microbiological study results of 48, 72 hours and evolution clinical data to narrow the antibacterial spectrum. When needed, fluconazole was added to the ABT regimen. On average, the ABT duration was 19 days, with gram-positive sepsis treatment lasting 2-3 weeks. In patients with surgical sepsis, septic shock, the source of infection should be identified and sanitized that once the diagnosis is made. Best practice recommendation. Etiotrophic ABT of surgical sepsis. For multi-drug resistant Pseudomonas aeruginosa, colistin or piperacillin tazobactam were the preferred options in patients without kidney disease. For Acinetobacter, the choice was limited to colistin and sulperazone. For carbapenems-resistant Pseudomonas aeruginosa and Acinetobacter strains, colistin was selected. In cases of sepsis caused by Klebsiella pneumoniae, colistin and amikacin were used with confirmed sensitivity to specific drug. For MACA and coagulase-negative staphylococcus infections, glycopeptides were employed, while alenizolide was chosen was vancomycin for vancomycin-resistant strains. Transfer decisions were made individually based on a comprehensive assessment of the patient's condition dynamics. My criteria for transfer included positive dynamics, infection-focused sanitation, reduced leukocytosis, PCT value less than 0.5 nanogram per milliliter and pediatric SOFA score less than 3. PCT study revealed that with timely sanitation of the purulent inflammatory focus and adequate etiotrophic therapy, this biomarker showed a clear decrease in strain. Conclusion: survival rate 86%. Our findings emphasize the importance of early sepsis diagnosis, rational antibiotic therapy with microbiological monitoring, prompt infection control, and non-aggressive intensive therapy with early vasopressor prescription for improved outcomes and reduced mortality.